Hello, everyone. Welcome to tonight's live broadcast, Pandemic Revenue Cycle Management, Perspectives and Advice for Community and Academic Practice. I'm Melody Mulaik, President of Revenue Cycle Coding Strategies, and I'll be your moderator for tonight's event. Diagnostic Imaging is pleased to bring you this webcast supported by Change Healthcare. Change Healthcare is the nation's largest healthcare technology and services company, offering both end-to-end software and outsourced billing and coding services for radiology practices. Visit changehealthcare.com to learn more. Before we begin, I have a few important announcements. This webcast is designed to be interactive, and we encourage you to ask questions throughout the event that will be addressed through the Q&A portion. You can submit questions by typing them into the Q&A box, which can be found at the bottom of your screen. We'll try to get to as many of your questions as we can. If we have any technical problems, or if you have any technical problems viewing or hearing the webcast, please click on the question mark help widget in the dock at the bottom of your presentation window. Now I'd like to introduce tonight's panel. I am joined by esteemed colleagues in radiology revenue management, including Christie James, who is the immediate past president of RBMA and is currently Senior Manager, Radiology Revenue Cycle Optimization at Massachusetts General Hospital. I'd also like to welcome Dr. Greg Nicola, Chair of the Commission of Economics of the American College of Radiology and Executive Leader of Hackensack Radiology Group. Together, we'll share our frontline experiences navigating the ongoing COVID-19 pandemic, its impact on payers, elective procedures, and telehealth, information on and experience with government support, as well as long-term solutions and investments for the future. We'll dive right in. I'd like to begin tonight's discussion with a focus on payers, reimbursement, and billing. So we'll start off on the payer side of it. And Christie, why don't you talk a little bit about maybe what you've seen with how COVID has impacted some of the payers?
First of all, thank you very much, Melody, and also the people at Diagnostic Imaging for inviting me to participate on this panel. It has been, as well as for everybody else, a very challenging and I can't even tell you, unprecedented times for everyone at work, everyone in their families, and also your coworkers. And as we move through this journey together, we are learning this we're learning this every day. Everything's new. And as we move forward, we have to keep our eye on the ball. We have to be innovative. We have to react to changes on a dime. And in doing that, we obviously will make mistakes and we try to clean up the best we can. But in my experience over the last, I guess now since March 11th, I haven't stepped in my office since March 11th in Boston. I'm actually up here in Vermont. And today, unfortunately, they extended our remote working until June of 2021. So it's not gone away. But at the same token, they've given us the tools to do our job well and to do it effectively and efficiently. So the payers, they're trying to learn as fast as we are. They're trying to take their systems and trying to navigate it to accept the various modifiers and challenges that we have currently. There's just the interesting part is that, of course, the telehealth component of it, your televisits and so forth, that volume went up extremely high, like 75%, whereas our volume in radiology went down and plummeted close to 75 to 80% in some circles. And the challenges of trying to maneuver your rev cycle around that is significant. And for the payers, they had a lot of difficulty trying to apply to the new modifiers that are required, the new documentation that is needed, the new regs and regulations that are put on by CMS or even on the state level. So all these things we are all learning together, and we have to use our patience, but at the same time, we don't have a lot of patience because we're losing a lot of money. So we have to build in robust systems to make sure we capture every single charge possible and to get those charges out the door and make sure that those charges or the claims process is as clean and efficient as possible. And of course, we have to leverage all our technologies and I have to say I have a lot of discussions with our IT teams constantly and also with our payer relations folks. And I think we've done a really good job, Melody. I think from the payers' perspective, the payers here in New England, have been very receptive to us all. And from a radiology perspective, I have not seen any unnecessary denials or anything like that due to the pandemic, or delayed in reimbursement. I don't know if you've experienced it in your areas, but I'd like to see, Dr. Nicola, if you have.
No, we haven't seen any delay, but then again, we were mainly a diagnostic radiology practice. We also do interventional radiology. So more of anything else, our revenue was just massively declined during this crisis. From a payer perspective, though, I think their job, and what we've seen in our area is they've done this job very well, is they had to listen what our needs are. Medicare did that, and certainly some of the commercial payers. I don't think they were in a position necessarily to dictate payment policy as opposed to listen, what are our needs in this crisis and how can we adapt our payment policy to match those needs? And they've done a fairly good job with that. They had to be extremely nimble. This is extreme disruption, and they had to pilot a large ship in a different direction quickly. From just a radiology perspective, our payments went massively down. However, now we've started to come back up. We're seeing a bit of a rebound. Some modalities were not quite at where we were before, for example, screening mammography, but we haven't seen a delay in payments at all. Pre-certification is still moving forward. We still have to deal with pre-certification, but because it was a fairly gradual upswing back to normal volumes, I don't think that was as much of a barrier as we thought it would be.
We were hoping that the pre-certification requirement would have been actually stopped for at least through this time, as we all adjust to the new normal, if you want to call it the new normal. But we have not. They have not stopped the pre-certification. But the one thing I did find out today, or actually Friday, is that Cigna has stopped their hard steerage program based on site of service. And they have postponed it until January of 21, but we're also thinking they may postpone it to the 2022 because they understand the hardship this is having on the healthcare providers. So we recognize that today because they were trying to hard steer some of our cancer patients to other facilities outside of our system, but they backed down on that today. However, the other payers continue with their pre-certification and referral platforms. So unfortunately, that's still here to stay.
Yeah, and the American College of Radiology did lobby against having pre-certification requirements, especially during the recovery. And most of the commercial payers did decide not to take that advice. But I can say just from a practice perspective, we haven't had too many barriers, mainly because the ramp up back to volume was slower than expected. There wasn't this flash of patients that all of a sudden came. It was more of a gradual increase in patient volume. In my area, where we were out of the first peak, I'm in New Jersey, so we actually have fairly low volumes of actual coronavirus at this point. So we're seeing patients come back, but at a slower rate than we thought. And so there haven't been much of a barrier for pre-certification. However, I can't speak for many other specialties. For example, pre-certification on surgeries and multiple other things may have had more of a hard time than we did in imaging.
Thank you both for that perspective on it. This is a follow-up, Christie. One of the comments that you said was that one of the things you're focused on is, ensuring the clean claims go out the door to make sure there's no disruption of payment. Is there anything in particular that you would say that you focused on with that, or that quickly comes to mind that you would say was more focused on during this time period?
Well, to be honest with you, we furloughed or we decreased our coding staff based on the volume, obviously. And when that volume came back with a vengeance, and I'm saying that because we went from probably a 50% capacity all the way up to maybe 101, 102%, not capacity, excuse me, from baseline. Now we've surpassed our baseline from last March. We're 2%, probably 2% above that now in our CT, MRs. And not plain films. I have to say that our plain films still lag, but ultrasounds are back up, diagnostic mammograms in those areas. But what we did focus on, Melody, is the coding aspect of making sure that we have robust coding systems and that we were nimble enough to start that engine right back up and make sure that we didn't compromise on the quality of it, and making sure that our diagnosis codes are what they should be when they go out the door. And especially if it's a COVID-related diagnosis, we had to be extremely careful on that, where we held back some of those claims to make sure that the COVID diagnoses were in the right position and didn't disrupt our reimbursement. We were very, very careful on that from that perspective. But we also implemented a lot of claims manager. I'm not sure if our audience knows what that means, but what that is more of not a clearinghouse, but more of a scrubber. And we have some very robust scrubbers in our rev cycle, where we're just turning these claims against all these rules and LCDs and obviously all the other types of rules and regs that we come across over the years. And we just make sure that it's extremely robust and that it can turn quickly, and that our physicians are also finalizing the procedures very quickly, and that helps too. And we're able to code right upon finalization, and then we get it through to claims as quickly as possible. And our rejections have not increased. Our denial rate has not increased. Our write-off has not increased. Actually, it's decreased. So that's good.
Oh, thank you, Christie. Shifting a little bit over to elective procedures, and Dr. Nicola, you mentioned some areas have decreased more than others. How, as a whole, not only for your practice, but maybe what you hear from colleagues as well in other places, how the elective procedures have been impacted and how you feel practices are rebounding now?
Well, the elective procedures were decimated for a few months. They just weren't happening at all, but basically because there was many state mandates that they couldn't happen. So that's actually where most of the diagnostic imaging volume plummeted. We had at our worst, we were down 85% in northern New Jersey. That was brief. It was for about 10 days. But we were down a lot, and it was mainly because there wasn't elective procedures. Those slowly ramped up in our area. A lot of doctors were holding off seeing patients in the private community and just doing telehealth for any emergency type visit, but actually planning surgeries even took longer than the state was ready to ramp up, the hospitals were ready to ramp up. The private practice doctors were actually taking it more cautiously. So we saw elective procedures ramp up slower in the private community than they probably did in more of the employed situation. So that took a while for us. And now we are starting to see numbers about what we would see prior to COVID.
So kind of as a tag on with that, how did that, you think about how did the practice respond to that, and how did that impact your clinicians as well as your staff from just an overall staffing standpoint, vacation times, furloughs, those types of things?
Yeah, we had to cut staff, we had to furlough staff, and the partners did not, we have about 20 partners in our group out of about 45 radiologists, and the partners did not collect any salary for 3 months, for about 2.5 months.
Wow.
So just to keep our business afloat. We have outpatient centers that we own outright, and we wanted to keep them at a minimum amount of throughput and keep some of our staff busy there. And keep those doors open as much as possible. We did consolidate resources across our imaging centers. But in order to do that, the money given by Medicare and by the government through the Payroll Protection and also from the Provider Relief Fund were just not enough to make sure that we could keep our business afloat. So we forego partner salary for that long.
Wow, that's very significant. Christie, from your standpoint, what are some of the things that you did?
Well, what we did was, from a senior leadership perspective, because it's a very large healthcare system, they took a cut in pay, and they also we're very, very fortunate to have a pension plan here for all of our employees. We're now called Mass General Brigham. Partners Healthcare is no longer the name. We rebranded ourselves during this whole process. So we're now called the Mass General Brigham. So all of our employees, our pension was no longer funded for a year. We also no merit increases, no bonuses, but nobody was laid off, and everybody still collected a paycheck. Now I have to say, this is because we were in an excellent position going into this whole pandemic. from a cash position, we were in excellent shape. So we lost a lot of money. I can't tell you what that exact amount is, but we did lose a lot of money. We did get some money from the government, like everyone else. And we are able to get back on our feet, what I heard the other day, because our volume came back so quickly, that our pensions will be refunded probably at the end of this year. So we didn't have to wait the whole year like they said. Of course, the merits or any kind of increase in salary has been postponed. I don't know for how long, probably a year or more.
Yes, speaking from the private practice community perspective, depending on how you're incorporated, this was a potentially bad time of year, depending if you're C or S Corp or LLC. Most of us have pass-through income, so there's not a lot of money left inside our businesses. This hit in March, which is right when we're starting to finally build up some savings in our bank accounts. And that's awfully early in the year. If it happened later in the year, we have a bigger enough cushion to weather this, but it happened early enough that it became quite difficult. And that's one of the reasons why we did not pay partners. One of the other reasons is because of our tax structure and because we have pass-through income, we have to be very cautious about the fall. I suspect we won't shut down elective procedures in the fall, but that is a guess. And if we did, our business has to have money available to it to function. And we also have to expect that we probably won't get relief funds from the US government anymore. And so we've built up a significant cash reserve by not collecting salary as partners so that we can weather any potential rebound in the fall.
Right. We have to do what we have to do. Yeah. We all have to, if we're going to keep our jobs, we have to do what we have to do.
Yeah.
A lot of different sacrifices, definitely in a lot of different ways. And to your point, there may not be government funds for that in the future because we don't know what things will hold. Just to kind of along those lines of the initial wave of things, because I think, some people now we're on the kind of the other side of the fact with government funds with that. But in terms of the government assistance that was available or may still be available, is that something that Dr. Nicola, your group had the opportunity to take advantage of? And if so, what was the benefit of it? If not, what was some of the thought around that?
So we did take both the provider relief fund from the Health and Human Services Department, which just showed up in your bank account. You could end up not attesting and rejecting it, but it basically showed up in your bank account. The issue there is that it's taxable, and that is something we're going to have to deal with in the end. We also applied for and eventually got, although it was stressful and a bigger hassle than we ever thought it would be, the payroll protection money. And there's some issues with that as well about the deductibility from your accounts as well, which still aren't ironed out and can become an accounting problem at the end of the year, depending on how that money is treated. So honestly, I'm glad we took it. I think it helped us weather a severe storm here, but there are still a lot of unanswered questions on what that money did for us and what is going to be the consequences of taking it. I don't think will be answered until near the end of the year.
Yeah,
good point.
In our experience, we did take advantage of the advanced Medicare payment, as well as most people probably on this WebEx or webinar have. And the only thing is we don't know when we have to start paying that back. What we understood, it was 120 days from the date of receipt. Well, that's gone. That 120 days is past, right? So we have not heard from our local MAC when we have to start paying that back. So I'm guessing that I'm going to wake up one morning and then we stop seeing Medicare payments. That's kind of like where I'm at right now. We probably will stop seeing Medicare payments for 120 days or until that amount that we received in the advancement is paid off.
All good reasons, no matter what your practice pattern are, to have some cash on hand come that fall, because there's a lot of unanswered questions here.
No, it's a good point. Well, let's talk about some of the things that, COVID has taught us. While COVID itself obviously is not a good situation, there's some things that have come out of COVID as we look to do some things differently within the organizations, within the practices. And one of those specifically would be telehealth. And Dr. Nicola, how has telehealth impacted your organization, or what's a way that you've implemented that in new ways during COVID?
So my practice specifically, we've done some telehealth with the interventional radiology department, but it's not something that we do on a robust fashion, and the diagnostic radiologists aren't performing telehealth. But I think it speaks to that little things can disrupt the market, and not that this was a little thing, but little things can disrupt the market massively and change how we all practice. And I think we all have to think outside the box moving forward. We always have to be experimenting with new ways to bring care to patients that's better and more patient-friendly. And telehealth happens to be that in many different specialties of medicine. And in all honesty, if we would have experimented with it more, we probably would have come to that conclusion sooner than having to wait for COVID. But we haven't practiced it that much on my side of the practice. What we have seen in the early phases of telehealth is that we've seen, this is anecdotal, and I think it needs to be studied. It's something we're actually looking to study through the Economics Commission. We've seen more imaging coming out of telehealth visits. There's too many factors right now to guess why that is. It could be because the patient hasn't seen a doctor in a while. But what we worry about is that telehealth may remove the face-to-face visit and make a doctor more uneasy about making a diagnosis or making a judgment call on a patient. And does that lead to more downstream imaging? And that may be an impact to telehealth that we don't know right now. And I think it has to be studied when the market settles. Right now, there's too many variables for why a patient would be imaged, but as it settles, that could be a consequence of telehealth. And we need to let the politicians know and everybody else after we study this robustly, because we have seen it anecdotally even before COVID that could lead to more downstream imaging, and we need to keep an eye on it.
Oh, that raises a really good point. With a whole other conversation is appropriate use criteria, which we won't dive into in the COVID world. But Christie, I know with telehealth for you and your organization, there's been some different things that you've been doing. Why don't you tell us about that?
Well, in the IR space, we're looking at building a more robust telehealth program, because we see that it will eventually help our patients obtain care that much quicker. We've seen evidence that our patients, like from the time we're seeing a referral is received to the time that patient actually has a biopsy or has an IR procedure, that time period has been shortened by so many days. So from that perspective, we see that it has shortened the length of time of care from the time of a referral to the consult to the procedure. So that's actually a good thing. I also want to say that I'm all for telehealth. I'm glad that this has been pushed into this quicker than not, because we probably would still be where we were before COVID in our evolution of telehealth. And I don't know how many on our call who have seen their doctor through telehealth, but I kind of like it. Unfortunately, I have to say I have to see my eye doctor personally, and I had to go down to Boston for that. But all in all, I like it. One of the things that startled me, I read somewhere, and I can't recall, and I should have wrote this down, that they're predicting a 40% lower detection rate of cancer because of the low imaging volume that we've had over the last 4 months. So they're thinking that, to your point, Dr. Nicola, that we will end up having more imaging, but is that going to plateau? I don't know.
Don't know. Yeah, it'll be an interesting, I think anytime we change our practice pattern, we need to study all the downstream consequences. And this is a significant change in practice pattern, and it likely is going to have a downstream effect on all of anybody who supports that practice pattern.
Yeah, it's interesting with telehealth because I think, as you mentioned, this is not something, if things were going to go on its own before COVID, Medicare probably would not have been as willing to cover telehealth visits. And some people have even said, a lot of times innovation occurs in wartime, and arguably this pandemic is kind of a wartime environment that forces some different things, and it'll be interesting what stays and what doesn't stay related to that. Well, let's look as we look forward into the future and we think of how our world has changed and what COVID-19 has done to us, and thinking about being a disruptor. How has that changed what's that post-pandemic world look at? What are some long-term investments that you would see for your organization, whether it's in safety, operations, workflow? I'll start with you, Dr. Nicola. I mean, how do you see the world changing for you?
Well, again, this is something we just touched upon with telehealth. It is unfortunate that patient-centric care needs disruption in order to motivate us to provide. So I'll give you an example. We talked about telehealth, and I think a lot of patients would like telehealth, and now it's hopefully here to stay. But we now have virtual waiting rooms inside our offices.
Right.
Why would anybody want to wait in a waiting room before or after COVID, but especially after COVID? And it's a shame none of us really implemented this in a robust fashion prior to COVID. But now we don't have patients waiting in waiting rooms. That's potential office space we can use for exam rooms or more imaging modalities. It is now space that patients don't have to conglomerate and potentially pass infections to each other. Patients like it because they're in their car or not even at the appointment yet. They've pre-registered. They don't have to come into the facility until they're ready to be imaged. It's way more patient-centric than what we practiced. And again, I think going forward, what it taught my practice is let's think of other things we can change that are patient-centric because they're the right thing to do, not because of COVID. But certainly that's one major practice change we made is the concept of no more waiting rooms. And you pre-register, you get a text message when you're ready to come in, somebody waits for you at the door, walks you to the imaging modality, you don't pass by staff that you don't need to pass by, you don't pass by other patients you don't need to pass by, and you get your imaging done and you leave. And I think that's a real benefit to how we've altered our practice.
Oh, that's great.
How'd you keep your volumes to the point where you need to be with that kind of scenario? Because I know we had to extend our hours and open up on weekends and so forth. And also we had to supplement, well, we aren't, but I've heard of others that are supplementing with tech aids or other type of non-technologist help or support. I didn't know if you have that.
Well, some of the electronic registering has cut down on the duties of some of the office staff. So they have more bandwidth to help us with some of these other initiatives. So they can mold their job that way. Some of it, frankly, is that our imaging volume is only ramped up slowly. Unlike what you've talked about, our imaging volume still it's close to 100%, but not quite there. So we still have a little capacity left in our imaging centers. Also, unlike what the utilization factor states that we're using our advanced imaging equipment 90% of the time, I think in most community practices, we're not. Our CT volume has never approached 90% utilization on our advanced equipment. It's more around 40 or 50%. So we've always had bandwidth to manage that. MRI is a little bit different story. However, most of the throughput problems on MRI isn't necessarily registering the patient and doing all the screening. For us, it's just honestly imaging the patient. So the rate limiting step is imaging, and that hasn't hurt us as much. So I think a lot of different hands moving into different positions and taking on different roles. Having a lot of electronic pre-registration has helped cut down the time and allowed people to alter their jobs a little bit on the front lines.
That's good. How about you, Christie, with some of the different things that, as you're going forward into the future, that you're looking to do differently or already doing differently?
Well, I could speak from a billing service or billing office perspective and coding. The good thing about where we were or where we are is that we were able to turn on the telework switch fairly quickly because a lot of our staff was already teleworking. We've had a lot of experience at that. Actually, when I first took my position with Mass General back 18 years ago, I can't believe it, but I at the time asked if I could telework one day a week because of the burden of driving on I-93 and the traffic and so forth and the parking and all the above. We recognize the hardship it has on our staff. So we already had people working 2-3 days from home anyway. But we took over 500 people and just turned it into teleworking within 100% within 3 weeks. It was pretty impressive. And from that perspective, we turned out things are a little bit more efficient, and then there's things that are not so efficient. So we're working it out like anybody else. We're constantly working through transparency models. We are meeting not every day, but we tend to have touch points. Our senior leadership staff is being extremely transparent and with everything that we've been working on in the last 4 or 5 months, and which has been great because it gives people a little bit more comfort that they know what's going on. And so we try to remain completely transparent through daily communications from senior leadership, as well as from our the billing office leadership, as well as from each other. I meet with my staff 2 or 3 times a week. We touch base, touch each other's IM through team working, or what do you call it, Teams, through Zoom. We have all these other applications that we use, and it seems to work out really well. And we're able to share documents very easily, and we can, it's like having someone right next to you with the technology that we have in place right now. For example, I mean, I could look at all of my dashboards and share that with my staff, and then they can have input at any given time, instead of having to schedule a meeting room, wait for everybody to show up. Our meetings are more efficient, and we can actually accomplish things within a half hour that usually used to take us an hour. So from that perspective, we're a lot more efficient in our time. And then the coding always was 100% remote, which was kind of interesting. We were actually ahead of the curve on that, so it wasn't new to us, Melody. I like it because I'm up here in Vermont, obviously, and which is really nice. But there are those people. Actually, there's one of my staff who has small children, and they've canceled school. So her young one is in kindergarten. So how do you do remote learning for kindergarten? So these are the challenges that we have, and we have a lot of support mechanisms in place with the Brigham and Mass General. And our employees, I mean, we really feel that leadership has taken the initiative to make sure our employees are safe, well, and have the tools and the support that they need to get their jobs done.
Yeah, two anecdotal things I've seen about our practice does a lot of telemeetings now because we don't want to meet face-to-face. The 2 issues I've seen, though, with it, number one is we can put out fires well over virtual meetings, but really thinking of taking the practice in a new direction or doing serious problem solving has been more difficult than it was face-to-face. And I do worry about that in the future. We've also added a couple new team members over the last couple months, and I think building that camaraderie and that teamwork and the trust to believe that person can do a specific task is extremely hard over interactive virtual meeting as opposed to face-to-face. And so I do see some long-term problems with continuing to function in this way, and that hopefully there'll be some hybrid in the future where we're able to build up a team and build up trust in people face-to-face, and also do some serious problem solving face-to-face, and then still put out fires virtually.
I think you hit on
That's a good point.
Yeah, very good point. I think you hit on something about the trust factor and making sure that everybody trusts everybody through open transparency at all times, in my perspective. But a good point you made was on, for example, strategic planning, or be able to draw stuff on a board and put our minds together and brainstorm on things. Yeah, I think that's lost if we're not in person. And you're right. I think that may prove to not be a good thing in the future if we don't have that ability to meet.
I think one of the other things is, I think one of the other things, and this subject comes up a lot, and specifically in radiology, I think it comes up in medicine as a whole for providers, but particularly in radiology, there's been a lot of discussion around burnout and the concern about our providers becoming burned out. And I think in a COVID world, there's a little bit of that concern even heightened with the fact that people are isolated. Arguably, a lot of people work even more hours than they did when they were actually having to go into any place. Either of y'all, has that been something that you've looked at within your organization or in your practice of how to engage people, or how to evaluate that, or are doing things to prevent or treat it? I know it's a hard question.
Yeah, it is. Go ahead, Dr. Nicola. I'm thinking that radiologists had more of a burnout than...
We've implemented drastic scheduling changes that looked at ways to get people ingrained with staying at home and doing some, I don't consider telemedicine, teleradiology. I think they're very different, but we do more remote readings so people can have some home time and not be exposed to COVID at the hospital. So we've changed our shifts enough that we've gotten such good feedback from the radiologists that they're really appreciative of having some more home time with their kids, being able to have more flexible rotations where they get a couple outpatient rotations a week and can start working at their own pace instead of always being getting phone calls about emergent care. And we used to mix emergent care and outpatient work sometimes on rotations, and you always felt like it was emergent work even if it wasn't because of the fact that it was mixed. And by separating that out, I think we've created a better work-life balance and allowed people to work at their own pace and their own time. But I think a lot of practices had already done that. But for us, that actually helped us through much of what's happened recently with COVID, really adjusting how people, what people are doing on a day-to-day basis. But that's about all we've done.
Yeah, we're a lot more flexible with the time. We understand the complexities that a lot of our workers have or employees have with their families. Like in Boston, as you all know, real estate was, I don't know about it anymore, but it was something that was hard to come by near our work. So a lot of people would have 1 bedroom, 2 bedroom, small little spaces to work in. And when you have children and all of a sudden your spouse is working from home and you're working from home, there's really not any space to work. So what we have done is we've been very flexible, allowing people to work later in the day or earlier in the morning so that they could take over the taking care of the kids while their husband is working or vice versa, or wife is working. So we're very flexible. We have to be very flexible. We're very flexible in our communications where if you hear the dog in the background, hey, let's see the dog. Or if you have kids that are, knocking on the door or whatever, bring them in, have them say hello and make them part of the experience. And that's something that I think has helped a lot for our employees. There are some employees that would really like to come back to work and be in the work environment, in the office environment. However, I don't think that's going to happen anytime soon. And how do you maintain the well-being of your employees when you're not going to see them for a year, face to face? So it's going to be a challenge.
Absolutely. We're going to dive into stuff a little bit more, but just a reminder to everybody, if you have any questions that you want to pose, if you'll go ahead and type those in the Q&A, in a few minutes we'll open it up and we'll answer those questions. But just as a reminder, if you have that, you mentioned at the beginning of the session, Christie, and in case everybody wasn't logged in yet, you mentioned that your organization has officially said that you're not going to be coming back face-to-face until June of 2021, right?
That's correct. For those who can work remotely, yes.
Wow. That's pretty, we're hearing that in different places where people are going ahead and, initially everybody was looking in terms of weeks and, in the middle of March when everything shut down, it was weeks from now or even potentially a month, and everybody thought that was such a long period. And now you hear people talking the end of the year, and you're the first that I've heard to say as far as June with that. But I think if people make those types of decisions, it enables them to do planning that needs to happen with things like that, which is really kind of interesting. A lot of the healthcare facilities and organizations that we work with, do not allow outside people in. So not only are the employees not coming in, but outside vendors, outside other entities, are not actually going in. So I think it just changes the whole experience for everybody associated with healthcare and those types of facilities. That's interesting to do that. One question to tag on to the thing you mentioned, Christie, with your dashboards that you work with and looking at it, is there anything that's changed in terms of what type of metrics that you look at or any of your KPIs or anything that you use to measure the practice during this time, or have you found that it's pretty much stayed the same?
A lot of things have stayed the same, but we also look at our average daily charges a little bit differently. We do it on a rolling 14 days just so we can see if we're going to meet budget or not. And we take our average daily charge amount and we apply our conversion factor to predict out 1 month, 2 months, 3 months out based on, for example, let's say what we did 2 months ago in June, what was that average daily charge? And if we stayed at that average daily charge for the next 2 to 3 months, how much money will we lose? And that's the kind of thing that we stayed on top of every week. And every day. The other thing we did on a weekly basis is we took that same kind of methodology and we applied it to our charges, and we broke it down by modality. We broke it down by site. We broke it down, actually just really down to a level where we can measure if volume is going up faster in this sector of the city versus this side of the city. We were very careful on how we took that data and presented it. And now we actually do it every week, that they like it and it's here to stay, even though it takes a lot of work. But they're here, they like it. We are thinking outside of the box, some of the indicators to make sure we keep our eye on the ball. I constantly have these dashboards in front of me every day. It's almost like I'm in the command center and just looking at all these widgets and so forth, because you can blink and be off $1 million where we are. So that's what I always say, you can blink and be off $1 million. And I'm not kidding, that's how much money comes through our system. So from that perspective, it's the same ones, Melody, that everybody monitors. One of the ones that I like to do is the adjudication reports, 2 months out, how many claims or what percentage of your claims are being adjudicated, and that's matched based on the post date. So if I look at my June's dates of service and I look at them today, what percentage of those are paid? Is it 90%, 95%? That tells me how clean my RCM is. And then if it's 6 months out, what does it look like back in March now, right? Am I back to where I was at 97%, 98%? These are kinds of things I look at on a daily basis.
Good. One question, Dr. Nicola, when you think about, how RVUs are used and how a lot of the provider groups, not all of them, but a lot of provider groups use it based on RVUs, has the COVID situation impacted how your group looks at RVUs and across the practice, or have you heard in other organizations where maybe they're valuing the physician's work a little bit differently or getting creative with that?
Well, I can't speak for a large organization with multi-specialties. I can speak for my practice alone. I mean, we gave up looking at our reviews for several months. What we did is just gave lots of partners time off. The only way we looked at our reviews is to look at absolute volume and then made staffing decisions. We only need 1 radiologist that day or 2 radiologists. That's about it, but we didn't hold radiologists accountable for productivity for the last 3 months. We'll ease back into that as we see our volumes level off and come back to where they were. But we weren't holding people accountable for that. The other hard part about holding accountability for RVU is that your case mix means a lot in radiology RVUs. There are modalities that really aren't, even though you think of RVUs as completely comparable, apples to apples, they're really not. There are certain specific CPT codes that have been devalued over the years and others that haven't. And it can lead to quite an imbalance trying to compare a neuroradiologist to a body radiologist.
Right.
And then when you send a radiologist in to just do everything, including neuro and body, now they have a mix of RVUs that don't make sense to you anymore. So really, until we get back to where people are just doing their specialty and then we can look at just their specialty RVUs benchmarked to where they were before, it's awfully hard to hold that kind of accountability.
No, that's a really good point. Christie, anything you wanted to add for that from the RVU piece?
No, I think I don't really get into the productivity part of it, but I do want to point out that CMS did publish the proposed rule with the new RVU values, and also what that is the impact it's going to have on radiology, and not just radiology, all specialties, and it's significant. So I stress those on this call to do the analysis on that and what the impact's going to be on your practice, and please get involved with your local associations, your radiological societies, ACR, Radiology Business Management Association, because they need to advocate on our behalf. Not only do they need to advocate on your behalf, but you need to advocate. The fact that CMS is going to apply a 10.6% reduction on the conversion factor is going to impact everyone. So we need to look at that. Please do the exercise to see the impact for your practice. We did that analysis on Thursday, Friday last week. It's significant for our entire enterprise. And for radiology, it actually turned out to be almost 11.3% reduction for our book of business, because we have a lot of global, we own physician-owned imaging centers like Dr. Nicola. So it wasn't as big of a hit if you were just a professional-only house. So please, I stress the importance of getting involved with your associations, also involved with your local leadership to make sure that this does not happen. However, our government probably needs the money. So it's, a double-edged sword. So I don't know.
Yeah, I think
that's a good point.
This is a fix that is going to require all of us do grassroots efforts with our congressmen and senators. It's not going to be fixed by regulation at this point. It's very likely going to have to be a statutory fix. The physician fee schedule has really been flat compared to inflation for over 2 decades, and it's a real problem. To put this in perspective, this is just a reshuffling game. We're dealing with budget neutrality. One specific service, E&M, the evaluation management face-to-face office visit, went up significantly, and rightfully so. There are some valuable patient interactions that occur there. But because it's budget neutral, Medicare decided that the budget neutrality was going to stay within the physician fee schedule, and all the money to pay for those escalation and evaluation management services would come from other doctors. And that's what happened specifically to radiology. The conversion factor went down because they had to pay for the E&M services. I want to put this in perspective, because not only do we have an 11% hit, and trust me, the American College of Radiology is working very hard with Congress right now to look at ways to mitigate that hit, but we also have a hit occurring in a time where we have exciting new innovations happening. For example, machine learning, artificial intelligence applications. How does a profession revolutionize itself and bring absolute state-of-the-art patient care when you're having a 10 or 11% hit to your fee schedule? How do you actually bring in artificial intelligence as an application when you can't pay for it? You can't even pay yourself what you were earning the year before. And this is a real problem with the entire physician fee schedule. And we all have to start thinking about, well, how does the fee schedule promote innovation at the same time as paying doctors fairly? And it's a complex question that I think is going to have to be addressed by Congress for sure.
Can I ask a question real quick to you, Dr. Nicola? Should we advocate for everyone to ask Congress to waive the budget neutrality for this?
Well, I think Congress is going to have a hard time waiving the budget neutrality, mainly because there are lots of sectors of the economy that are suffering, and to waive it would probably not make a lot of sense. But that would be great if they could waive it for a period of time to phase it in, or at least at the very least, study the implications of this E&M policy. We're still not quite sure what the downstream implications of raising one set of CPT codes by 20-25% is on the rest of healthcare, and on the overall health of patients. And that's something I think that absolutely needs to be studied. Congress has acted in different ways in the past. For example, the American Taxpayer Relief Act, if you remember, Congress used to have to step in at midnight to patch the doc fix, the old SGR formula that would dictate that physicians were going to get a steep cut, and Congress would come in and find money. And in the past, Congress has actually found that money within Medicare itself and maintained budget neutrality. They just didn't ask physicians to pay for it. So Medicare's a large shop that includes drug pricing and many other different payments that they could look at to patch this without violating budget neutrality, but still maintaining a reasonable, healthy payment inside the physician fee schedule. So I don't know what Congress is going to do. I think they have several options. I hope they do something, because I do think these hits are prohibitive for bringing innovation forward.
I think phasing it in would probably be your best bet on this if we had any say in it.
Thank you for the question and the answer on that.
Yeah, you're still faced with, even if it's phased in over 3 years, you still have a 10 or 11% hit happening to a specialty that's trying to bring innovation forward. And I still think that's problematic, but anything that they can do to soften this is probably welcome.
Okay, well, we're ready to jump into your questions. Remember, you can submit questions by typing them in the Q&A box at the bottom of the screen. Our first question is, how do you see COVID impacting your hiring or promotion practices over the next year? Christie, you want to take that one first?
Well, it's interesting you say that. Yeah, it is going to impact it. I'm right now in the process of hiring new staff because we're merging our billing offices to get, the Brigham and the Mass General billing offices on the professional side are being merged, and there's some holes that we need to fill. So yeah, we have a freeze, but we don't have a freeze, and that's the kind of thing that we're working out. Especially with this merger, we definitely want to make sure that the radiology component of our billing revenue cycle stays robust and not compromised in any way through this merger. So we have a lot of work to do. I think ultimately we'll work out. I have no doubt. Everything always works out, right? But we have to be smart about it and take one step at a time. I do have lots of candidates, so that's not the issue there. I have some really good candidates for the jobs. So you're right, Melody, it's going to be a tough situation. Salary-wise, we obviously have to stay competitive and so forth, but we do have a freeze. But for this particular instance, we may lift it a little bit.
Yeah, it's interesting. I think we're flipping where normally it's been hard to get a lot of good revenue cycle staff members. I think it's kind of turned, and unfortunately, there's a lot of people that have been furloughed or have lost their job in the process, and now it's a little bit more of an employer's market than an employee's market, at least for a lot of places and organizations. Dr. Nicola, what about you?
We really are just have to be careful where our volumes at are all times and stay nimble with that. So we had made a lot of staffing adjustments during the COVID crisis, including reducing the number of radiologists we have in our practice. And right now we're all working harder to try to maintain the volume and to maintain the service we have. So I don't think in the short run we're going to do much. I think that we're very concerned about the fall and what the impact is on our volumes, and that we are not going to hire or necessarily shrink our practice anymore until we have some idea of what's going to happen in the fall.
Okay. Kind of another question, given the latest delay in the AUC mandate for that, what recommendations, Dr. Nicola, would you give to practices going into 2021 as they can continue to deal with your balance in your revenue cycle, your balance in dealing with COVID, and we do have the extension of the implementation or the testing period for AUC?
Yeah, so for those who don't know, the appropriate use criteria of that program that was launched by PAMA has been delayed another operation and testing period year has been added. So there's no penalties associated with the program now until 2022. That being said, I think most hospital networks have already bought the infrastructure and have already started looking at how to implement it in the outpatient setting. Now, speaking from a private practice perspective, we're aware of the vendors, we're aware how it works. We've gone around and discussed what has to happen to our referring doctors, but we have not bought the technology because all along we've been worried it was going to be delayed over and over again. So I'm uncertain what Medicare is going to do with this program. We're now going on 7 years without implementation. I think Medicare has some concerns on how they're going to implement it. It's an incredibly unpopular program amongst many of the physicians out there. And even the college has advocated for altering the program so it's not real-time feedback, but instead done through a registry mechanism. So quarterly you can give clinicians feedback on how they're doing. What Medicare does with all this, I'm uncertain. They're right now under statutory obligation to some point implement this program. But I would say if you haven't bought the technology and you're nimble, and that's key, I would probably wait until it's clear it's going to be implemented, giving yourself a few months to implement it. But if you've bought the technology and you're in alternate payment models, there's probably wonderful ways to look at imaging volumes and control imaging utilization inside fixed capitated payments. In fact, there are a number of ways to get registry type feedback from it and look at outlier clinicians and have interventions with those outlier clinicians to try to look at appropriate use of imaging. So I think that it just depends what your situation is on how you'll move forward with the program.
Okay. We've got another question in, and I don't know if this is something that either one of you have heard of. Michigan Blue Cross Blue Shield recently announced a 30% premium credit that they'll be issuing to individual policyholders. Do you see other Blues plans or national commercial carriers following in this trend? Christie, have you heard of that at all, or of actual insurance carriers giving back information on that, or giving back credits to the policyholders?
When you say credits, like if they don't use their policy.
No, it's think about what Allstate did, right? So when COVID came out, they knew we were all at home, and so for those of us at Allstate, we got a whopping $60 or some sort of credit on there. Blue Cross Blue Shield Michigan is doing that for their policyholders because they're not using their health care.
No, I have not seen any of that. No.
How about you, Dr. Nicola?
The dental health plan did give us a credit. Let's see what else did. I think that was it. No, okay. Nobody else did. But they did advertise record earnings over the last quarter, I guess.
Yeah, I think the record earnings aren't very good PR for insurance companies at all. But at the same time, I think any business would be prudent on holding their money until they know what's actually going to happen in the healthcare system, because I don't think any of us have a crystal ball and have any idea whether a health insurance plan is going to spend more money or less money by year end. I'm not sure. They saved a lot of money for 3 months, but there's still a lot of months left in this year. So I'm a little surprised that they're already making those announcements. I understand why. I think it is terrible PR for the insurance companies right now to be raking it in this health crisis, why hospitals are struggling, doctors are struggling, nurse practitioners are struggling, patients are struggling. No one wants to see somebody have an absolute massive winning. So I get it, but there's a lot of caution left in this year.
So as we look at, we've got a couple of minutes left, and before we wrap up, if you were, as kind of a final word of advice that you would give to organizations, Dr. Nicola, what is it you would say? We've heard you say definitely take into account your cash flow with that, but what else would you add to practitioners as well as administrators that are listening tonight?
Well, I think that the lesson I've learned from this, and it's something I have an entrepreneurial background and I've always thought about, but it's always hard to implement, is that disruption's always around the corner, no matter how stable you think you are. The imaging business has been really not disrupted and been stable for far too long. And the people who are going to survive are those who are going to disrupt their business in the right way before a crisis happens. And we should all start thinking about how to provide imaging more efficiently and more patient-centric and not wait for COVID to tell us how to do it or the next crisis, because we can do much better than what we do, and we just have to think outside the box and start implementing that change.
Thank you for that. And Christie, what would you say?
I agree with Dr. Nicola. One of the things, or a couple of things, is continue to, like he said, think outside the box. Robust RCM technologies, leverage as many technologies as you can to make a very robust RCM model or system. Leverage your coding, automated coding applications. Those kinds of things. Just ensure you're nimble like that. I understand Dr. Nicola has been using that word. I think it's so true. Staying nimble, be able to be reactionary and proactive on how you move forward. Explore new ways to do things. Always explore, always brainstorm. And that's what we do every day. We're always challenging ourselves to do better and to look at things differently. And also I work very closely with the doctors because I need to hear what they're seeing. I need to actually understand their operations, their workflows. And then also the shift to the APPs or the advanced practitioners has been very instrumental in moving our platforms, our patient care forward. And I think working closely with them and keeping them educated on documentation and making sure the documentation is robust and that we can code appropriately from it. So yeah, it's like all of the above. I mean, just your RCM from front to finish, from the time they're scheduled to the time you receive money on that claim or a denial, that you constantly keep track of everything to make sure it works. To be
Thanks,
simple.
Christie. Yeah, and I think just, in closing, as you said, you've got some great input tonight for everybody attending. I think just to reinforce some stuff that both of you said is that we really, as an imaging community, have to share stories, have to collaborate together with the different entities, organizations, locally, at the state level, at the national level. And, that's one thing that's always been great, I think, about the radiology community as a whole, is people really do try to work together for the better good of the patients and for the providers. And this time, more than ever, related to that. So sharing the stories, the good, bad, and the ugly, not just in a COVID environment, but outside of that, to provide the best patient care for it. So unfortunately, we're out of time. I want to thank the audience for attending and participating in tonight's event, and especially extend our thanks to our panelists, Dr. Greg Nicola and to Christie James, for a very informative discussion, sharing your experiences. I would also like to thank Diagnostic Imaging, the host of this particular webinar, and Change Healthcare for making tonight's webcast possible. Thank you so much for joining us. Good night.
Thank you, Melody.
Thank you.